Um, I would also like to acknowledge with respect that I am here on the lands of the Lekwungen peoples. This is where I work and raise my family, and to the Songhees and Esquimalt and Wasanic peoples whose historical relationship with the land continues to to today. So, um, as Esther mentioned, I'm a nurse practitioner in oncology, which is why I'm particularly interested in access to cancer treatment. And my dissertation work focused on barriers. As we know, cancer affects many Canadians, but the cancer burden is not evenly distributed. And despite Canada's publicly funded healthcare system, there is persistent and widening inequities in access to healthcare, particularly for people who experience structural inequities, such as homelessness. And I should also preface this talk with we don't normally think about cancer treatment as a palliative intervention, but I'd say that the majority of the people that I see or at the cancer center are on that more palliative trajectory. And that's really an arc from the time that you get a life-limiting diagnosis, as you know, to kind of what we think about at the end of life, which is kind of where we more focuses in terms of, or we more think about palliative care more towards that end of life. But there really is an arc. So, cancer treatment can be really thought of as both an upstream intervention to prolong life or improve quality of life, but it can also be helpful right at the end for things like symptom management, like pain, for example. Um, so, just a few key concepts. I know that we're all familiar with what healthcare access is, but there are many different definitions of this. And I like to think about it as the interplay between the distribution, delivery, and availability of healthcare and the approachability of these services, juxtaposed against the ability of an individual or group to obtain care to achieve their best health outcomes. And this complex interplay is against the backdrop of our political, our economic, our social, and historical contexts that inform our society. When I refer to cancer treatment, it's a broad term used that refers to approved, active, and/or maintenance therapies to cure, control, or slow down the progression of cancer. So in the palliative setting, it would be to slow down the progression of cancer, as well as treat symptoms. Just going into a little bit of background. So this is a slide that I really like that really breaks down about, why do people get sick? And as we can see, the majority of the reasons aren't necessarily related to biology. We can consider things like environment and contexts. And so when we think about things like access to social determinants of health that are unmet, or people who face greater barriers to accessing healthcare. And this is just, when we think about that in terms of, I guess, accessing cancer treatment, for folks that have many unmet barriers or unmet social determinants of health, this kind of prevents people from being able to take advantage of the advances in research and technology that have led to better treatment that, many people are able to access today, specifically folks that are homeless. So we know from population health research, people who experience homelessness are more likely to be diagnosed in later stages, advanced stages, have higher rates of preventable or screen detectable cancers like lung or cervical cancer, for example, and ultimately experience much higher rates of cancer-related mortality compared to people who are or that are housed. And so again, on that palliative trajectory, treatment is one of those ways in which we can support folks. However, research shows that people who are experiencing homelessness are more likely to have treatment delays, receive treatment outside of recommended guidelines, have higher rates of missed visits or discontinue early, and all of that can impact the treatment efficacy. So we'll move on to just a few of the findings from a few papers. These are published so that you can read them. So we're going to go through that just as a kind of high-level overview of that before we go over um, some more focused work related to homelessness. As part of the dissertation, I wanted to better understand first some of the contexts and barriers that contribute to some of these outcomes, which resulted in a publication. One was a secondary analysis of ethnographic data from my PhD supervisor, Dr. Kelly Stajahar, and the other one was a scoping review looking at barriers in high-income countries. And to summarize these findings, barriers were multifactorial, again, arising from the social dimensions of health, such as access to stable housing, um, uh, also geographic distance. So, depending on where you live and the distance away from a cancer treatment facility, and the availability of societal benefits, such as income supports. And then at the individual level, many contexts such as trauma, experiences related to stigma, disabilities alongside comorbidities such as serious mental illness may mean that, among other things, may mean that some people avoid cancer care altogether. And at the level of the health system, there was a generally just a mismatch between the way that cancer treatment and care is designed and delivered to meet the needs who face major structural inequities such as homelessness and come from care. And in the next few slides, I'll break down like a few of those findings at the organizational level. So first, the impact of health literacy. Um, so as we know, health literacy affects how patients can understand, engage with their care, and in turn, this can influence their outcomes. So implicit, like a lot of the cancer treatment, uh, is delivered in more of an outpatient setting. So this really requires people to have a higher degree of health literacy to self-manage a lot of aspects of their care. Um, and mismatches occur when cancer information, such as appointments or, information about their diagnosis or their treatment, was not delivered in line with patients' literacy levels. And this made it harder for some of the participants in the focused ethnography in particular to understand their treatment options, where to go for tests, how to manage their side effects. And it also led to some mistrust in the cancer system and also providers. So these things together contributed to, factors such as missed appointments, delays, or just deciding not to go for treatment altogether. In the example shown here, this participant who was homeless had missed opportunities to build health literacy, which caused him to miss the critical window for which treatment was effective. So another key finding was that access to social care needs like stable housing, food, transportation, access to things for communication, such as a telephone or computer, or income to cover out-of-pocket expenses was critical to starting, adhering to, or completing cancer treatment. And in our secondary analysis, all of the cancer participants were facing many of these unmet social care needs, and we're also navigating both the social care system and the cancer care system without a lot of like intermediary support of people that bridge those two systems. Um, and that's just really related to sometimes people not identifying that those needs are there, and therefore, appropriate like referrals of people like social workers who may be able to help with that or support people better are just not done. So if they're not identified by kind of everybody from the onset, kind of those interventions kind of have that or unmet interventions have that ripple effect, and people um, uh, just weren't supported. And most folks also, even if there are things like brochures and stuff like that to point people in the right direction, It's just like people are given a lot of information when they're first diagnosed, and many are unaware of supports that are available kind of in the cancer care sector. And again, both studies highlighted that all of the barriers kind of demonstrated are not just one, but are often occurring at the same time. They are complex and often compound with one another. The scoping review identified that, in some studies, people with multiple unmet care needs faced greater barriers. And both of these studies, the preliminary studies, truly highlight that access to safe and stable housing was a key social determinant that impacts access to care. So for the remainder of the presentation, I'm going to focus on some of the findings from this focused ethnography and exploring the impact instead of just the barriers. So recognizing that, social contexts such as homelessness impacts not just the individual who's experiencing the structural inequity, but also people working within health and social systems as well. So, data collection for the study was nested under the umbrella of a larger ethnography led by my PhD supervisor, Dr. Stajahar, on caregiving for vulnerable and marginalized adults. And I was one of the graduate students at the time employed as a research assistant to collect data. And because there are high rates of cancer in the homeless population, I focused on a subset of participants who had cancer and that were undergoing treatment. So this more focused ethnography draws from 120 hours of participant observation and 28 in-depth interviews in one Western Canadian city. So, as a research method, if you're not familiar with ethnography, it's a qualitative method that operates on the premise that everyday experiences serve as an entry point for understanding the more complex and less visible social processes and structures that shape people's lives. And it considers both individualized experiences as well as the kind of larger forces outside of the individual that shape, people's experiences. So methodologically, ethnography allows for interpretation to bridge, micro, such as the individual, and macro, more that kind of policy or organizational level to gain a deeper understanding of how, in this case, unmet social and structural determinants of health shape access to cancer treatment and care for folks experiencing homelessness. Um, a focused approach is based on usually people have more of an insider track, so they either work with or have lived experience. And in my case, I came from an oncology background, so we chose that kind of more focused approach, knowing that I have that kind of cancer background, so I could zoom in on more things related to uh, people's lived experience and gaps in my own understanding. So ethnographies, we use a lot of participant observation. So we, are following people around, taking a lot of field notes. So it mirrors a lot of what we think about as anthropology. It does have roots in anthropology. And so with that, there comes a lot of ethical considerations that we have to consider. Um, and that's why we use things like theoretical frameworks to position ourselves as well as the research. For example, ethnographies that are situated within a critical social justice or health equity paradigm attempt to challenge dominantly held assumptions, including, your own, that create conditions and structures that are responsible for inequities. And as a researcher, in this, you have to, we're not neutral, and we bring our own positioning, values, and assumptions into all of the research. So reflexivity is one way of engaging in critical self-reflection to recognize how we are also shaping the research process. and also how, what we're interpreting affects knowledge creation, especially, in contexts of inequity where there may be power dynamics that mu must be acknowledged and actively addressed kind of throughout really the whole arc of this type of work. Um, and, like negotiating access is a term in ethnography that refers to the process of building ethical relationships with participants. And this requires, careful and ongoing engagement, um, especially with people who experience structural vulnerability, where research can feel quite extractive. This dynamic is highlighted in a document called the Manifesto for Conducting Ethical Research in Vancouver's Downtown East Side. I like one of the quotes that states that research can be costly for our community and has rarely actually benefited us. So consequently, foregrounding some of the data collection for the research involved extensive, for this project, it involved extensive preparation and training and mentorship going into it, as well as just a lot of time, a lot more time than what the hours report of really developing relationships. And it was really facilitated by, Dr. Sajahar's research relationships with community-based organizations, as well as partnerships with a mobile equity-oriented palliative care team. So I'll go into that a little bit more detail in the upcoming slides. And then, of course, reciprocity. So that's not just ways in which we can sort of uh, tokenize or tell people, give people monetary compensation or thank you, but it's also just kind of doing things throughout. So, as a researcher, you're not a fly on the wall. You're certainly doing things like helping people move or doing things in ways that you can. Um, and as a clinician, that was definitely an ethical tension for me. Knowing that, when you're coming in with that healthcare hat, you think that, oh, I can, there are ways that I know what to do in a certain situation, but as a researcher, you're kind of disempowered to be able to do that because you'd be altering the research field. So it's really just kind of like working with people's care teams, and letting the care teams really do the work that they do so well without really intervening in healthcare, which is easier said than done sometimes. Yeah, I could go on about this. This could be a whole other presentation, but we'll move on for the sake of time. Um, so before starting, I did mention interviews, so we'll go through. We did the interviews after we did a large portion of the observational field work. So initially, this started through us observing the daily work of the mobile palliative care team. This included going out with team members on visits to see their clients living in a variety of different housing sites, such as emergency shelters, transitional housing, long-term care on the street, hospice, inpatient units, you name it. And then we also saw how people engaged with different community-based and health and social services, as well as, in my case, the cancer treatment facility. And through this work, then we established relationships with a smaller number of clients, and this was done over like many, many months, and then began going out with them independently once we had, yeah, formed relationships. So there's a lot of work in kind of entering those relationships and also ethically exiting those relationships. And again, probably a whole other topic if you're interested in ethnography, but a lot of things just around that. Uh, so the findings, oh, sorry, there we go. There we go. So we identified four themes using an interpretive thematic analysis, and we'll go through some of those key things. So the first theme is this the right choice, weighing the competing priorities of unstable housing with cancer treatment. This is a very long quote, but it highlights how cancer treatment becomes more complex for folks experiencing homelessness. Some clients, upon learning of the treatment risks, decline due to fear of added suffering, given their environmental circumstances. And there was a lot of moral distress also experienced by people in both the cancer care sector as well as the social care sector. Um, for example, ethical dilemmas arose when oncologists had to consider how treatment could be supported safely within the context of challenging environments. Shelters, for example, are often crowded, and people may not even have access to clean water or a fridge or, a place to for secure storage for medications or, their own bathrooms. So things that we kind of take for granted, honestly, when we're prescribing some of these things. And then the next theme, the next theme, it takes somebody how non-traditional support networks sustain access to cancer treatment amid housing precarity. Again, a long quote, but this theme really highlights the
Really?
importance of, oh, should I pause?
Yep, you're good.
No.
Go ahead. Yeah.
Okay. Um, Yeah, the next theme highlights the importance of caregivers in the context of homelessness. So many of the people that we worked with were estranged from their biological or legal, what we call biolegal family. So support comes in many different ways. And in this study, it was more often community-based workers, such as outreach, housing, and harm reduction workers who stepped in many ways, went above and beyond their paid roles. And the presence of a caregiver was really critical to overcoming a lot of barriers associated with homelessness. For example, in this reference to this quote, this oncologist felt more comfortable prescribing immunotherapy because the patient was connected with a support worker. And in the next theme, attending to cancer treatment without a fixed address, how cancer, community health, and housing organizations contribute to the ecosystem of care. We did a little bit more of it's a pretty broad theme. So, in all honesty, we did a little bit more of a deeper dive on the organizational contexts within the cancer care sector and how kind of other organizations were also interacting with that with the cancer sector. Um, but really, within the cancer organizing, cancer organizations are site-based models. So they're a brick and mortar place that's delivering treatment. We're not going out into the community, and that poses actually a lot of so many barriers, but it places burden on people to navigate all of these different systems. And when we know that what works best for people are really places where people don't have to travel too far, that services that I think a lot of community care or community health does so well, which is more wraparound services or having multiple different more modalities in one building, and really kind of in a hospital setting. It requires people to come to you. So really the main finding was that flexible, relational, and community-based models of care, of cancer care, would be needed to kind of bridge gaps better. As we also found with the focused or the secondary analysis, the social care needs, if they were invisible or just not addressed, it just caused a lot of kind of ripple effects. So, for example, in this context, if like housing instability was not assessed up front, it placed the burden on people to disclose, sensitive information, which also might be very difficult for folks experiencing things like trauma and stigma and medical mistrust. Um, and it was a lot more successful. There are certain roles or teams within the cancer care sector. So, for example, palliative care is often does a bigger social care needs assessment and often can identify those things up front. that kind of goes off that palliative approach really works. I think in a lot of ways, in identifying some of the more social aspects of care, as well as specific roles, such as in the cancer care settings in BC, and there are many different types of roles, but we have Indigenous patient navigators that have been also instrumental. But the gap is that if you don't qualify, if you're not palliative, if you're not of Indigenous identity, then there's a gap for other people that may not have that, and so they're kind of filtering into the what we call like the regular stream of things, and I think that's where a lot of things possibly aren't caught, and where there may be some room to improve. Um, yeah, just sort of, teams or roles that had time to build rapport, to connect people with different types of support networks, to coordinate resources and build trusting relationships, just were better able to facilitate access. So really it shifts kind of, the focus from how do we help patients, meaning the individual, navigate the system, to how does or should the cancer system, how should the cancer system uh, engage or change to reach and support patients. And lastly, this is more at the policy level. So housing as healthcare, the structural role of policy in cancer treatment access. So, uh, health policy is not always aligned with the needs of people experiencing homelessness. Really, there's just a severe shortage of appropriate housing. And so, because housing is limited, um, it just creates a lot of challenges. Like we found that a lot of people were on wait lists for months and months and months, and this can have like an impact on in so many ways, or if people were housed, if their care needs became greater, sometimes they would often lose their housing um, because it's not the fault of the housing sector, but they are also not organizations that can support people to often die or in place, or for people that have a higher degree of just healthcare needs. So, when people were admitted to hospital, they often lost housing in those contexts. And it's just a tricky thing, I think, for everybody involved. And then, as we highlighted, just sort of housing does not always mean housing that would be ideal for undergoing something like cancer treatment or dying. So, uh, units may lack privacy or just accessibility to things like elevators and stuff like that. So there's just like a lot of the buildings are some are great, some are just like need a little bit more care and attention. For example, like one participant couldn't attend any appointments because he had a disability where he couldn't walk and the elevator was broken. So that creates, as you can imagine, so many other challenges, not just in healthcare, but just access to things like food and things like that. Um, so really, it, you know, it's just kind of an ongoing challenge. I think it's kind of one of those things that housing really has a huge impact, and I'll just leave it at that. But uh, you know, some recommendations that came out of the research. And I like to focus on things more kind of, I guess, within my purview of what can I do if I can't change a housing policy and build a bunch of houses? Like what are we able to do to kind of help move the needle a little bit more as especially as a healthcare provider? So the organizational level recommendations were more targeted towards the cancer setting, and that's just because we can't focus on absolutely every setting, really. And just to kind of narrow it down to that. So when we're thinking about health equity, one of the core principles is directing resources towards people with the greatest need. So, we, as in cancer care, we can influence this by addressing some of these, I guess, mismatches in the typical approaches to the way that we deliver care, and the people who come for care who may have greater health or social care needs. And I should preface that, many people and individuals are already doing these things, but I think it just needs to be kind of more systematized and organized in a way that people are doing things kind of all of the time. So a few small things, and this is just like from this research, there's going to be many, many more things that you might be even able to identify in your own local contexts. But uh, yeah, we'll just touch on a few of the points of this pie chart. So in the top left in blue, comprehensive intake stems from the research, which found, that people fell through the cracks, who were unable to complete treatment when the social care needs were not met, as we discovered. Um, and so the recommendation here would be to conduct a comprehensive social care needs assessment around the time of consultation. So when people are actually diagnosed with cancer. Um, and this may trigger different types of referrals, for example, or connecting with different community-based organizations to help support people. And nurses are often positioned as the first points of contact for that type of intake process, and therefore could be, ideally placed to take the lead. And also, not to mention that, but it's also like clerical staff as well are pretty instrumental in some of these just like initial first points of contact. So it is many people within the healthcare system that could act as that touch point. So next in the orange domain, enhanced communication. This means several things. So first, it just means being attuned to variations in the health literacy. It also refers to communication required for care coordination, which is a lot greater actually for folks that are connected with that need maybe multiple different things that are is outside of just kind of their biomedical needs. This might be being connected to other care teams in the community. It may be looking into other informal caregivers such as like housing workers, neighbors, et cetera, that might not always be recognized in the chart, but are doing really important care work that facilitates access. So this would include kind of understanding more deeply of who these folks are that are important, and what roles they play in documenting this. I think so often we call the secondary contact is always like the person's, family member, biological family member, and isn't always though they may be estranged from that biological family member. So it's not always those types of people. And I think probably the presentation yesterday highlighted that a lot. So just kind of using creative strategies with the pre-existing things that we have to document, and providing things like if it is if people are connected to teams and community, or people, that you're providing details like what are the working hours of their support worker so that you're not booking things like CT scans at midnight and things like that. Because so often appointments are missed because there just really isn't somebody to bring people to appointments, or, even transportation and things like that don't work outside of regular hours. So yeah, I think it creates it's both practical, but also creates visibility for all of this work that's already being done, and it can really enhance collaboration between sectors. And this brings me to the next recommendation, which is intersectoral collaboration. So one of the barriers that was that people are again both navigating both this like social care system and the healthcare system, And there are also, again, medical silos within healthcare, in between specialties, community health, mental health, etc. So a recommendation would just be create like more partnerships between cancer community. And this might be done in a variety of ways, depending on your local context. But from this work, one of the effective strategies that we observed was when a nurse from the cancer care sector attended multidisciplinary rounds that were hosted by the mobile equity-oriented palliative care team that happened once a week, where they could discuss mutual clients. And like so many magical things honestly happened from just this 1 hour meeting. And it really helped a lot. It just streamlined that care coordination, and allowed people to engage in like on the spot problem solving. And it just, it, you know, it helped almost immediately. So some of those things you think they're small, but they're actually quite large in the context when things are not always being done like that. So lastly, in gray, the last bullet point is building capacity. So that really means building capacity for equity-oriented healthcare, which is a bit of a buzz term. But broadly, that includes embedding principles of cultural safety, anti-racism, knowledge of trauma and violence-informed care within workflows, as well as training, people on the impact of substance use stigma, and examining implicit bias around like really all of those things. Um, yeah, so it's just kind of thinking, challenging these dominant assumptions within our own kind of healthcare settings, and thinking about outside the box ways of the usual approaches to care. Uh, okay, so last slide, because I know it's been a while. So the findings also, emphasize the impact of roles and teams that were able to meet people where they're at within community, to provide on-the-ground support. Um, and my pie in the sky dream was to create a mobile model of care for oncology. All of those things, all of these dreams sometimes are really related to is we're seeing more cutbacks in healthcare. But it's just, it would be great if there were more roles that could meet people in place, that could provide more on the ground support and symptom management for people who may need it in community. Um, and, you know, and secondarily, related to just capturing some of this. So, uh, I'm reminded of the phrase, what is treasured is measured. So thinking about carefully designed metrics that could also shed light, not only shed light on inequities in our system, but also support equity related initiatives so that the impact of those initiatives can be measured and sustained over time. And I know many colleagues are working on this, and just research takes a really long time. So it's yeah, it not research can't always support really things um on the ground, because it would be great to just have maybe even more QI over this, but I do think some visibility around that helps maybe support the sustainability of programs. Um, and then lastly, we at the policy level, we just need more housing for people who have life-limiting illnesses such as cancer, and otherwise. So that is a wrap. So thanks for staying with me, and I'd love to hear from all of you.
Thank you so much, Amber, for sharing your research, and also that was such an insightful presentation. Thank you once again. So now the floor is open for us to entertain questions based on some of the ideas that's been shared, and also just connecting it with our own experiences and areas of practice. If you have a question, please feel free to raise your hand, or you can add your question to the chat. We'd love to hear your thoughts and reflections as well. Yes, please, you can go ahead, Katrina.
Hi, Katrina Aparicio here. I'm a palliative care physician on the downtown east side. I work at Mays Place, and totally, I totally agree with everything you're saying there. I used to work at BC Cancer prior to the pandemic and was trying to sort of look at this problem quite a bit because in the palliative care pain and symptom management clinic there, we were seeing clients who were from the downtown east side who just was struggling to make it to regular daily 8 a.m. radiation appointments, and we were trying to see if there were ways and means to make this easier for them. Unfortunately, this was a bit of not so much a project, it was just thoughts that I had, but the pandemic messed up any chance to follow that up. And since then, I've reinvented myself. So here I am in Mays Place, and I just want to say that, yeah, so many of those factors are important. We actually have a client in Mays Place right now. He's been with us about over a year, 12, 15 months. Came into us, had had one cancer treatment. It completely flattened him. At the time, he was very vulnerably housed. He was still using drugs. And he's a very vulnerable character anyway. And so he just tanked, and the oncologist quite rightfully said, we can't do this again. And he was unable to look after himself at home because he was so weakened, and it was thought that his disease was progressing. And so he was brought into Mays Place Hospice with the support of the Indigenous support workers on the downtown east side who actually knew him very well. So he's been here 15 months. He's so much better. We eventually got a CT scan just because we were thinking, he's going to be here forever. And his disease, remarkably, had not progressed. He'd put weight on, Amazing. He was much healthier. And so the oncologist, we went back to them and said, maybe you should look at this again. And so, yeah, he's getting treatment starting this week, just a one-off, a radiation. But enormous amount of effort has gone into this. And to get him to that treatment, because to some extent he's now quite institutionalized, having lived in hospice for a year, but he's not really eligible, and he needs to be having a proper life and be housed. And we're working on that too. But it takes such an enormous amount of effort and coordination to set this up, but it can be done. That's what I want to say. I don't think hospice is the place to do it from in general. We do have another patient here, and so the two of them are filling beds. This other one hasn't been here quite so long, and he's not got cancer but requires dialysis. So a similar situation. He has to go 3 times a week, and that requires one of his community support workers to come and take him to dialysis and go back and pick him up and make sure he gets home without sort of stopping off along the way and helping himself to whatever he feels the need to help himself to on the streets. But we have succeeding in extending the life of these patients. But I totally agree with you. The idea of these community-based, equity-oriented oncology / palliative care organizations would be a great idea, and I think wouldn't be totally impossible, because there is already a very good setup down here of support workers on the downtown east side and the community nursing teams who are well aware of these patients out there with cancer, with their diagnosis, and trying to access treatment, and will go to great lengths to support that. So I think that's a great idea. There was something else I was going to say about that, and I can't remember what it is now. But anyway, thanks for highlighting those issues.
Yeah, no, I mean, those stories are amazing and really echo a lot of what we were observing, which you can't always go into detail in a presentation. But just to say that I think I can't emphasize enough the importance of longitudinal support as well. And, basically sometimes to accept interventions like even going for a CT scan or cancer treatment or whatever it is, whatever sort of healthcare intervention, it really is that relationship of trust with somebody that they trust. It's almost like I'm here to support you through that because of all of the medical mistrust. So that's like, one
Mm,
of those things that I think needs to be kind of bolstered up a little bit more, because we think of those things as like a quote soft skill, especially when we have such a biomedical hat on, but actually that is
mm,
like a little bit of the like it's a key ingredient is are those things. So yeah, it's just yeah, care delivery is, as you've mentioned, like so complex. I think that people do need to be supported a little bit more, but particularly workers that are, um, uh, if just the cancer care, I think could support workers and just helping people manage symptoms a little bit more too in place because people typically know what to do. It's just some of those nuance of, what drug is this? What am I looking out for? And it
yeah,
can be a
yeah,
little bit scary for people too. Yeah, but also, when people, we found just like your story mentioned, when people had their social determinants of health met. So when they did get into a place like hospice, for example, it often people like were on death's door and then they perk up and they do phenomenally
exactly.
well.
Yeah.
And it's like, oh, wait, this person shouldn't be here. And they were dying last week, but, cut to being like having, like care, support, and basic needs, it can really go a long way. So, yeah,
Mm,
thank you for sharing those things.
thank you.
Hi, it's Nicole Wickjord. I don't know how to raise my hand. I work at BC Cancer in Surrey, and I've been working with people with health and social challenges. And one of the things that we've started doing at Surrey is interdisciplinary care plans, so including external providers. So not everybody is homeless. Most of them have um, other challenges, mostly substance use. And I guess one of my questions for not just you, Amber, but others across the that are listening in about how to get that longitudinal support. Because I found I work with Fraser Health, so they have a team when people are homeless, and then once they're in a shelter, they get a different team. And then if they're on OAT or not on OAT, it's a different substance use team. And so for a while, it felt with one client, I was like the continuous person as the clinical nurse specialist. And the man actually wasn't really having cancer treatment anymore because he was getting weaker and weaker. He had a lung cancer. So I don't know if anybody can comment on what they do to get that longitudinal support when they're kind of navigating all these different community resources. Thanks. Great.
Pause just in case somebody wants to chime in because other people may have some experience with this.
It's Katrina again here. I would say the way we operate for that, because I also work at Ground Spring Health, which is one of the community health centres on the downtown east side. So we have palliative care physicians embedded in the community health centres, and we go out to consult. So we're not providing primary care, we're not providing continuous care, but we go out to consult with the community nurses. But the community nurses are the ones who really provide that continuing care and coordination. And they might be nurses from the community health centre, or in some cases here, they're also from the primary care health centres and the downtown. So the most of the clients that I am involved with have one or two community nurses. If they're deemed palliative, then they're very well supported, I would say. When they're not palliative, yes, I agree, it's a little bit more piecemeal, but in the majority of those I've come across have been connected with a community nurse or support worker of some kind from either community health centres or from the primary care centres. And I think the primary care centres are the ones who provide that support when it's early cancer diagnosis, I would say. But
Totally.
yes, I agree, they
Just
do need one coordinator.
Totally. Just a quick thought on that. And the nuances about this, like the research stuff that we found is it's for some people when you're mentioning all those different teams, Nicole, it's I think that's really common that there are actually a lot of teams and even within those teams, because a lot of these positions people kind of also come and go, it is really hard to find that like one longitudinal person. Um, and some clients, because they're connected to so many teams, are almost confused as to who do I call for this or that. Like I remember one room I went into, they were very organized and had all these different teams of phone numbers written on their wall on a piece of paper. And it was a lot of different phone numbers. Like you wouldn't know, I wouldn't know who to contact for what if I was, it just was, but I think that then there was a meeting for that particular person. Again, this idea of like multidisciplinary rounds is a really good one because it might help to connect people with like who's going to be the primary person, the primary coordinator, given like where they're at. So if they're no longer really in cancer care, like who's able to assume that care and then kind of intersect with all these different teams seem to work a little bit better. But again, I was following a very well organized team that often was that hub for people. Um, but other people didn't have like a mobile palliative care team to do that. So this is kind of one of those things about the communication aspect of it is who's going to kind of be that person. And it sounds like that's you a lot of the time, Nicole.
Yeah, it has been. I was a nurse in the downtown east side actually in the early 2000s, but I find that there's some challenges with people who use substances with home care. We've got
Yeah.
people in many communities. It's not as concentrated as the downtown east side where there's lots of resources and home care doesn't have the same capacity to, if the person doesn't answer the door or doesn't answer their phone or they've lost their phone or whatever, they don't have the kind of resources to keep phoning or trying to track down people. Yeah, and I've had people lost to follow up too who are homeless, and even though we have these teams where we're supposed to case find patients, that they're unable sometimes to locate people. So that's another challenge, and these are not palliative patients, but I appreciate that you've worked with your research focused on teams that were very well established and focusing on the palliative population. So thanks. So I think there's some great generalities for all people with health and social inequity. So I really appreciate this, Amber.
Yeah, no, thank you so much.
Okay, so I'm being mindful of our time here. And I just wanted to say thank you once again to Amber and to everyone that was able to join us today and contribute to today's session. Just before we leave, I just wanted to let you know that there will be a short evaluation survey once you exit. It will pop up, and your feedback will be very important to help us understand what's working well and how we can continue to improve our echo sessions. We also aim to share the session recording, the summary notes, and any other resources within the next 7 days. So please keep an eye on your email for these materials, or you can also visit our center's website to learn more about upcoming echo sessions. And finally, I'll just be putting into the chat our next echo session on the 26th of August from 12 to 1 p.m. and it's titled Modern Palliative Care in the Emergency Room, what the PIT gets us talking about, and our presenter will be Dr. Dave Willis-Croft as our presenter. Thank you once again for joining us today. We hope you found the session valuable, and we look forward to seeing you at a future echo session. Have a nice day, everyone.
Thank you.